particularly from middle school all the way to high school. We focus on some college students, and our level of education is more particular on hands-on science. And in saying that, we have seen a lot of disparities in underserved communities that we've also started to work with to really kind of promote this educational piece. And I'm very honored to be up here moderating this particular discussion on diversity and inclusion in immunization. So without further ado, I would like to introduce our panelists. On the far right, we have Richard Sway, Dr. Richard Sway. And then we have Dr. Robert Johnson, Corey Robertson. Oh, I'm so sorry. I gotta read through my stuff. I'm really bad with names, as you can tell. So after Richard, we have Corey Robertson, who is Senior Director of Scientific and Medical Affairs at Sanofi Pasteur in the U.S. division. We also have Laura Lee Hall, who is Chief Operating Officer and Executive Vice President of Sustainable Healthy Communities. And then after Laura, we have Roslyn Foster of Palomito Family Medicine in Taylors. She is a part of the Prisma Health. And then we have Stacy Zulueta, who is also a pharmacist, and she works as Senior Manager of Quality Improvement at Walmart. So this discussion is going to be very amazing, and I think we'll start with the presentations with Corey Robertson.
All right, can you hear me? All right, great. So good afternoon. Can you hear me? Okay. So good afternoon. I want to thank some of the organizers for this opportunity to present today. What I plan to do over the next few minutes is discuss the importance of influenza and influenza vaccination. This is probably going to be lost on any millennials out there, but I once heard an ID specialist refer to influenza as the Rodney Dangerfield of infectious diseases because it doesn't get the respect it deserves. So hopefully over the next few minutes, we will all leave here with a healthier respect for influenza. Next slide. So this is one reason why we should have respect for influenza. Of all the vaccine preventable diseases, influenza has the most impact in the US in terms of cases. About up to 15% of the US population each year comes down with influenza. And this translates to hundreds of thousands of hospitalizations due to the flu and tens of thousands of deaths because of the flu. And this past influenza season, the 2017-2018 season, is a stark reminder of how important influenza is. This was the most severe influenza season on record. And as an indication of this, if you look at the graph on the right, you can see that the hospitalization rate due to the flu was about 100 per 100,000 population. And that was more than the hospitalization rate seen for the first 3 influenza seasons combined on that graph. So I showed the slide at last year's summit, and it bears repeating that the impact of influenza extends beyond the respiratory tract. Sure, influenza causes exacerbations of chronic lung diseases like asthma and COPD and can lead to secondary bacterial pneumonia, but influenza does have an impact beyond the lung. It's been shown to be a trigger for cardiac events like heart attack and stroke, and can also exacerbate chronic conditions like kidney disease and diabetes. And as evidence of some of the growing impact of influenza when it comes to chronic conditions, there have been a number of studies that have been published. The study on the left is a study that looked at the impact of influenza on persons who had a previous MI. And you can see that from that study, there was a 10-fold increase in heart attack in the first 3 days after influenza infection among this population, and an 8-fold increase in stroke. And when you look at diabetic patients compared to non-diabetic patients, when they come down with the flu, they have a 3 times higher rate of hospitalization, a 4 times higher rate of admission to the ICU, and a 2 times higher rate of death. So let's take a look at the graph on the right, which shows the impact of influenza immunization on diabetes. So you can see that influenza immunization has led to positive outcomes among the diabetic population. There has been a decrease in diabetic events, namely stroke, heart failure, influenza, or pneumonia, and all-cause death on the order of 15 to 30%, and also reduction in heart attack in this population by about 20%, although that statistic wasn't statistically significant. Now moving to cardiovascular disease, and I'm not sure how many people in the room are aware of this, but I find this quite compelling. Influenza vaccination, when used in people who have a history of heart attack, is as effective as smoking cessation, blood pressure control, and statin therapy in terms of preventing a second heart attack. So I'm going to repeat this again because I don't think everybody is aware. And again, I find this quite compelling. Influenza vaccination is as effective as smoking cessation, blood pressure control, and statin therapy in preventing heart attack in those people who have had a history of heart attack before. And this is even more compelling when you think about the flu shot. You don't need to take a pill every day for a year. And in terms of cost, we're talking about $15 to $40 for an influenza shot compared to $600 to $1,000 a year when you're talking about antihypertensive therapy and statin therapy. So despite the benefits of influenza vaccination, we're not doing a good job of vaccinating our population. So I recall earlier, I think it was Dr. Wilder, who had mentioned that we need to call a thing, and these vaccination coverage rates, they're sad. And Laura Lee, I think we can get angry about this. So looking at vaccination coverage in the US population overall, less than 50% of the US population gets vaccinated against the flu, and this has been consistent year in, year out, despite the benefits of influenza vaccination. And when we look at vaccination coverage by race and ethnic groups, Blacks and Hispanics are at the bottom of the pack with respect to the 2017-2018 season. So in conclusion, we have disparities with respect to race and ethnicity in terms of immunization coverage. We also have disparities when it comes to chronic conditions like heart disease and diabetes. And we do have a mechanism by which we can address outcomes when it comes to influenza. Now, I know there's been a lot of talk about influenza vaccines and they're not being as effective as we want them to be. And that's been taken to heart, and we are developing and currently have available vaccines that are able to provide better protection against influenza. So what we need to ensure is that there aren't disparities that exist when it comes to using those better vaccines. So I know I shared a lot of data here, but now the rest of my esteemed panelists will now provide you information about how that data was turned into power. So thank you.
Thank you, very nice.
That's perfect. Why don't we go right into Laura, and that way you can just tell us a little bit about your slides, and we'll have a big overview at the end.
That's great. I can hear that I'm being magnified. Thank you. Wait for my first slide. You know, I know after lunch and talking about the flu vaccine, that kind of isn't the sexiest thing, right? But when you heard what Dr. Robertson just told you, it's better than a statin and a hypertension medicine in preventing a heart attack. I mean, flu is like this ubiquitous, deadly agent that we could really do something very significant about. And the fact that only 1/3 of African Americans and Hispanics adults got a flu shot, when they have more of these comorbid conditions that are susceptible to hospitalization and death in the occurrence of a flu, I think you can become passionate about this issue because it's something we can do something about. Drive, that's the program that we've started, and it enjoys support from Sanofi, demonstrating rising influenza vaccine equity demonstration project. And my colleagues on the stage with me, outside of Dr. Robertson, are not seasoned speakers. They're going to talk to you about what they're doing in their practice in the real world, and we need lots of these kind of champions. So let me see if I can figure out how to move forward. I have to say, hooray for my team. I don't know if any other than Jeannie's in the room. Wait, go back. But here they are. We're a mighty 5 now. And we try to do way more than we're supposed to do at this number, but they're all really great, and here they are on this slide. So how did we get here? I already gave you a heads up that about a year ago, really about a year ago, we had an advisory group meeting led by Dr. Greg Poland, who is probably the foremost expert on vaccines in general. The members of this group were not only experts in vaccinology and flu, although they were there, we had other kinds of experts like behavioral economics, the nudge theory, right? Psychosocial experts, equity experts. We had stakeholders on the ground. So here's a description of it. Multidisciplinary panel of experts and providers. And they really wanted to kind of think about this under-vaccination issue and the racial disparities that may be growing and the impact on older and vulnerable adults. They reviewed a lot of data, including something that Corey didn't say anything about, was the biology of immunosenescence. As we get older, vaccines don't work as well, but there's an answer for that in our innovative companies. And we looked at the evidence for how you increase vaccinations. And we concluded what you're hearing an echo of, and I think it's important to echo because the more you kind of have it in your brain, the more you're going to become a passionate champion for full influenza immunization. Influenza is a serious threat to health, functioning, and independence for older adults and vulnerable adults, those with cardiovascular disease, diabetes, which is about all of us, right? And people don't realize that. They haven't connected those dots. There are not perfect vaccines yet. Hopefully there will be more perfect as we move forward. But there are actually some real strong options for older adults to combat that immunosenescence. It is unacceptable that we have a gap by virtue of race and ethnicity. And, okay, Dr. Greg Poland, he's like a geek, nerd, wonderful man. You would never imagine that he would be outraged and passionate and impatient for change like he is. I wish he was here with us, actually. And so we basically, as a group, said we need to have some action here. And you know what? We know how to make things change. There is an innovation science, and we can apply it to this. And that's actually what we concluded and published, and the press release came out today. Here's the article. And more importantly, that's what we're implementing. So we're working with healthcare systems in Delaware, Christiana Care Health System, Greenville. Greenville Health System is now at Prisma. Plaza del Sol Family Health Center in Queens. And Helen, unfortunately, could not be here to talk about their work, and I'll share a little of it because of a very sick daughter, and Walmart. So we're working with them based on this concept that we can rapidly demand change. And if we're on the wrong course, we're going to get off of it quickly and start another one. So how's that going to happen? Large systems. So you saw what I put up there. Those are big systems. Their reach ultimately is extremely large, and they can become the models for like systems. They were selected because Frankly, they decided they wanted to be a part of this conversation. They have leadership support, which is always important. They serve diverse and underserved patient populations. And I think it's a repetition, so let me move on. So the rest of our panel is really about efforts that we're making as a part of DRIVE. And as I said, Helen is not here, but let me tell you a little bit about who Helen is in Queens. I'm gonna just let you enjoy these statistics. They serve a lot of people. I couldn't believe when they were talking about how many walk-ins a day they get at this one site, the Plaza del Sol. Now, the exciting thing about, well, one of the most exciting things about this urban health plan and DRIVE are Maria Sanchez and Jorge Gomez. So that's a practice manager and a nurse. And they ran this baby, and they ran it beautifully, and they are so proud that they are part of the solution. So you guys, you're kind of the important people in your community. Enlist your RNs and your MAs and your practice managers and your IT folks and your community volunteers. They want to be part of a solution that means something more than just themselves. I can't say enough about Maria and Jorge. And so they developed a project where they did patient surveys, like what's the barrier? And so in Queens, their patient population is not born speaking English. Their patient population isn't born speaking Spanish. They're from Central America. Spanish is a second language for them. So there are some not only cultural but language issues. So they surveyed their patients. They did some QI activities to promote the flu vaccination. And then they looked at their patients with diabetes, excuse me. Here's their results, and I think this is my last slide. That among the unvaccinated, the biggest barrier to flu vaccines was lack of time and fear. Fear they would get the flu, mainly. Money was not a barrier. In fact, in a focus group, one gentleman said, if you were giving me that for free, I would think you were testing something on me. So they were surprised by that, because this is the entire adult population with a lot of uninsured. So they focused their QI project, Quality Improvement Project, on making it fast to get vaccinated and to alleviate fear. So they had a nurse, they have an immunization station, and if you walk through that door and it's, yes sir, I want to get a vaccine, you are shuffled right over immediately to get that vaccine. They also instituted, they trained up their front desk and MAs, LPNs, and nurses so that they were making a recommendation in a presumptive fashion. This is the behavioral economics piece. It wasn't like, do you want to get your flu shot today? You know how we usually hear that at the end of the visit. It was like, your doctor says you're due for your flu shot today. And only those who said no, 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 and no to a variety of people, actually the doctor had to say anything to. So that's what they did. They were able to increase their flu shots in December, January, February, 15% in the general population. Okay, December, January, February, the graph is flatlined. Nobody is going to get a flu shot, even though you can and should if you haven't been vaccinated. They increased it 15%, and they increased it 21% for their patients with diabetes. They did note that they need patient education materials. So apparently the Spanish version of the CDC and other even privately developed patient ed materials use the word gripe for flu, which is not the flu, as every Spanish-speaking native knows. So that is like fighting you, right? If the word is something gripe, everybody knows what gripe is, and it ain't the flu. I mean, that's a problem. Too many words. That's another thing they found in their focus groups. They respond to pictures, and please use the right words. Anyway, I think that's my last slide. They are making big plans for next year, including a launch at a community fair in August. So we'll all have to go to Queens for that next August and more. Thank you for your attention.
It's going to Richard.
All right. Good afternoon.
Oh, wrong one.
So
I'm
Dr.
sorry,
Richard,
Sorry about that.
It's all right. Dr. Richard Sway comes to us from, he's an internal medicine residency. He's in an internal medicine residency program at Christiana Care Health System that's also affiliated very closely with Laura's work over in the Sustainable Healthy Communities LLC. So take it away, Richard.
All right, let's try that again. Good afternoon. My name is Richard Sway. Again, thank you for the introduction, Alazar and Laura Lee, for this opportunity to really present our findings at NMQF. Just to introduce myself, I am a third-year internal medicine resident. So for those of you who are not from ACGME or unfamiliar with a resident, we are basically the only doctors now in a hospital where you can one day see in the clinic, talk about smoking, the next week see after you've had a heart attack and us talk about smoking again, and then the week after schedule another follow-up appointment to talk more about smoking and follow up for your heart attack. I really want, because we rotate really everywhere in the hospital, in addition to just our primary care clinics. I want to talk to you about how we approached our quality improvement project, and it's titled Champions on the Front Lines, which really is because we focused on medical assistance to really increase our influenza vaccination rates in our urban and academic medical practice. So Wilmington Adult Medicine is a urban residence-based clinic in Wilmington, Delaware. We're the largest city in northeastern Delaware with a population of approximately 71,000 people. Our patients are very diverse. About 60% of all our patients document themselves as non-Caucasian. We have approximately 71 clinicians, 60 residents, 9 attending physicians, and 2 nurse practitioners, as well as 2 nurses. All of these clinicians are really part-time. Just like us residents, they rotate through the clinic on maybe twice or 3 days of a week. And I'll tell you why this is important shortly. But we have also 12 medical assistants in our clinic. And the role of a medical assistant is they're the first people that our patients, when they come through the door, they're the first people that they see. They're the ones who will ask you, what is your chief complaint today, and document that in the electronic health record. They're the people who will take your vitals, do your weights. And once you see them over and over again, they become familiar on a first name basis. But they're full-time. They're there 6 days of the week, and they do not rotate through, and they're full-time. And I'll tell you why that's important too, and why 12 to me was a greater number than 70. And I'm not bad at math, I promise you. When we kind of got the charge to increase our influenza vaccination rates in the area of Wilmington, Delaware, which had deficiencies in our underrepresented minorities, we took a look at our own clinic's data. And that was an arduous process in itself. But what we found was in 2016 season, we had 40% of patients who were vaccinated in our clinic out of, I think, 6,000. But the staggering number was that we also had 40% of patients that we had absolutely no documentation, no idea what their influenza vaccination status was. That means we don't know if they were interested in a vaccine, we don't know if they got it from elsewhere, we don't know if it just happened to be no one asked. And that, I think, was a problem we could not get over. So we implemented a PDSA, or those of you who are familiar with quality improvement model of Plan, Do, Study, Act. And to interpret this is we really had to observe what our systems were, which was the plan. We would do, which is implement and design an intervention on how to address this problem. And then once we had this intervention, we would study or observe how well that intervention worked. And finally, based on that study, implement a second round of interventions. So let me tie you guys back. We had a 40% gap in our data that we didn't know, every 2 out of 5 patients who walked through the door, whether they wanted a vaccine or whether they declined a vaccine. That was huge for us. The second issue that we were working with was this project kind of fell into our lap in October, but we were super excited because this was a great opportunity to improve our numbers. But because it was so late in the season, we really needed to do something quick and high yield. And we couldn't possibly, or we thought it would maybe much more challenging to address and engage with the 70 rotating providers, the residents, the attendings. But instead, we aimed to focus our efforts on how do we engage those 12 medical assistants, those first faces that the patients see when they come through the doors of our clinic. And what did we do with our medical assistants? We really aim to have a peer-driven engagement. And what does that mean? It means that we had one of them who was very well versed, almost like a super user, as you would call in the EMR or the electronic health record world, someone who is familiar with our own routines for documentation, someone who is well versed in how to document correctly in the electronic health record. And we encourage them to do two things: to standardize the process, as well as enhance data capture through documentation. Effectively, we wanted all 12 of them to ask every single patient who walked in our door if they wanted a flu vaccine, or tell them, I want to give you a flu vaccine. And if they said no, to document that and tell the provider. We studied the outcomes of this by doing manual chart review of about 15% of our clinic population in December, the month which we implemented this intervention. And we found that the unknown rate actually came down. And I'll go through this slide shortly. But that the influenza vaccination rate stayed approximately the same, 48% in November and December. So this is going back. So we took a look at that and said, well, something's working. We are decreasing that unknown rate. So what can we do better from this? We kind of gave a booster shot in vaccination speak and really re-engaged our medical assistants and found our vaccination champion who was from the ranks of the medical assistants and said, how can we re-engage the medical assistants and get them even more excited? We offered them incentives through a competition. Our medical assistants were divided into 4 care teams, and we said, we're going to have a competition between the 4 of you. We won't tell you what the prize is, but the group that gets the most data capture will win a prize at the end. And we also gave them objective feedback saying, after we've done this intervention, look at your unknown rates drop. It was by 15%. You've known more about our patients because of what you've done in this 1 or 2 weeks in which we did this intervention. And then we looked at the data again in January and in February, and that's what I'm about to show you next. So going back to November, this was before we implemented our intervention. In the blue is our vaccination rate, 48%, not too bad. But in the gray, you have a 40% unknown rate. In the next month after we did the first intervention, the unknown rate went down to approximately 25%, that decrease in 15%. So we redid the intervention again with competition, with objective feedback, and with peer re-engagement. And we found that the unknown rate decreased further, from 25 down to approximately 17%. And that had a concomitant increase in the vaccination rate up to 65%. We did not do any further interventions afterwards, but we did look at the data again in February, and we found that this change was sustained. So overall, we concluded that the message I really want you to have is, I think having inclusion and diversity is really, really vital. And having an enhancing performance is vital. But we have to really take a close and honest look at the methods and the ways that we're collecting data to output that performance. Because we found that before we can really measure, how well are we vaccinating our patients, we've realized that 2 out of every 5 patients weren't even being engaged with. And we had to fix that first before we go out into the community, before we analyzed why people refused vaccines, which we also did as a secondary analysis. But we did this not through addressing the entire clinic. We focused on a small select group of people inside our staff, our medical assistants, who come and live in the communities in which we serve. And through peer-driven engagement, objective feedback, and competitive incentives, in the end, we threw them a party and gave every one of them, those very nice outerwear jackets, but with a logo that said Vaccination Champion, because that's what we wanted to celebrate for them. We increased our data capture of all influenza vaccination status from 60 to 85%. And the overall message is, our medical assistants were our vaccination champions through doing this. And we think they can be your vaccination champions in your primary care clinics, wherever they are as well. So thank you.
Next we have Dr. Roslyn Foster talking a little bit more to that only in difference in locations, or should be talking to us from Prisma Health.
I do want to interrupt you though. In Queens, they gave people, the winner of the contest, a free day off. I'm just saying.
We didn't give anybody anything. But anyway. I'm Roslyn Foster from Prisma Health. I'm located in Greenville, South Carolina. That's between Charlotte and Atlanta on 85. Some of you may know it. Prisma Health is an affiliation between Palmetto Health in Columbia and Greenville Health Systems, and that just took place the latter part of last year. So our question was, we needed to change our approach, and in changing our approach and also educating our medical assistants and the rest of the staff, can we increase flu vaccination rates? We had some hurdles to success. Physicians, I guess our hurdles were time. Sometimes it was time consuming once they said no, to go over all the various reasons why they should have the flu shot, why they didn't want to have the flu shot, their cousin had this happen. And it just took time. With the staff, our medical assistants, our PAs, our LPNs have so many other things they need to juggle, like callbacks. Giving the shot can be time consuming with people squirming and moving. You had to get them excited about actually giving the flu shot, and also the patients. I guess I think the staff was probably one of the biggest hurdles, giving them something else to do. Patients, why our patients declined the influenza vaccine. One, concerns about getting the flu from the vaccine. You just don't get the flu from the vaccine. If you did get the flu vaccine on January the 12th and you had flu and tested positive on January the 17th, you were already exposed to the flu before you had your vaccine. It takes about 2 weeks to get immunity. Side effects, oops, sorry, I gotta go back. Okay, side effects from the flu. The number one side effects really are local reactions: redness, swelling, tenderness, some discomfort. You know, rarely you get the more significant ones: myalgias, fevers, headaches. That's less rare. The flu vaccine effectiveness. Well, I heard the flu vaccine wasn't that effective. My response was, no vaccine is 0% effective. 40% may be better than none. I have a few statistics because I'm anxious. I had to write it down. 40% vaccine effectiveness will prevent about 60,000 hospitalizations. So that's a big deal. So if you can prevent yourself from possibly being hospitalized with the flu, that's a nice pearl to send a patient with. Healthy people do not need the vaccine. Approximately 20% of the population, like Corey said, get the vaccine every year, get the flu every year. Many of them have never had the flu. So in 2008, you know, I used to say, I'm gonna leave the flu vaccine for the old people. Well, I got the flu. And after that, I have gotten the flu vaccine every single year. I was my own obstacle. I wasn't the biggest proponent of the flu vaccine before I had the flu. And now I want everyone to get the flu. Sure, I felt better in a few days, but it was a miserable experience. And while I was there, one of my colleagues sent me all this information about the deaths and associated with the flu and the money I was losing by not being at work. So yay, I get the flu vaccine every day, every year now. Actually, the next year when we were our own private entity before we joined the hospital system, I actually got a flu vaccine in September and another one in February, which is not necessary, but I was anxious. Allergy to the flu vaccine. We hear about it all the time regarding the egg allergy. There is not enough egg or egg protein in the flu vaccine for you not to give the flu vaccine. And this comes from the Annals of Allergy, Asthma, and Immunology. They said not enough egg to cause an allergic reaction, and only 1.31 people per million have a severe allergic reaction to the flu vaccine. So that's another argument regarding why you should get the flu vaccine. It's really not an allergy situation. Your opinion is your opinion. Your perception is your perception, but do not confuse them with facts or truths. So that's what we really have to do. We have to dispel some of the myths regarding the flu. Okay, my perception and my reality with the study was different. I thought it was going to be a straight shot. Everyone's going to get the flu. My numbers were going to just skyrocket, and I'd be the queen of Prisma Health. It was more like the other side. And I fell off the road a couple of times. It is difficult to convince people who have their opinions regarding the flu to change their mind. It was nearly impossible for some. And no matter how many people, the ladies at the front desk wearing a "Have you had your flu vaccine" button, or my medical assistant talking about it, and then giving them something to read about it, and then me coming in and reinforcing it, it didn't work all the time. So our numbers were not as good as I thought they would be. We start from 0 in January for some reason, so I don't know why. So at the end of last season, we were right around the 40% mark, and we did get it up to approximately 58% by the end of February. I was really hoping for more of a 25% increase, but that didn't happen. I wanted to go up to about 65%. So we have made some changes to how we're going to approach it next year, and I'm hoping that those results will be better. What worked? Simple facts. You could die, okay? That's a simple fact a lot of people listen to, but what more people listen to is about their children and their grandchildren. You know, well, if your daughter's not going to vaccinate your granddaughter, I'll be honest, 80% of the child deaths last year were due to kids that were not vaccinated. You don't want little Timmy to die, do you? So, and you want to get the flu vaccine to try to prevent, you pick him up from school 3 days a week, you'd hate to expose him to the flu, then he dies. So, stories that end in death work. Every time I go someplace, is that a bad mole? My cousin had one like that and she died. It's not a bad mole. I'm not going to die. But death works. For the seniors who live at home by themselves, you want to continue to live at home, don't you? By yourself. You don't want to go into a nursing home. You don't want to have to start living with your daughter, you know. She's overbearing and difficult. You don't want to do that. So, loss of independence, a big deal. Permanent physical decline. Okay? Some of our elderly are barely hanging on by a thread. Okay? So for them to get the flu could take them away from their independence. That's a big deal. And worsening of chronic conditions. Death, the most significant one, but also a heart attack, a stroke, debility. You need a concise statement. You need the flu shot. We're giving you the flu shot today. That approach worked most of the time. You have those that nothing worked. But for the most part, we did improve. It is a work in progress. And hopefully next year, if I get to come back, we'll have 85%. I doubt it. I'm hoping for 70. I'm hoping for 70. And thank you for your time.
Next we have Stacy. Stacy works over at Walmart, so go ahead, Stacy.
All right. Hello, everyone. Thank you very much for having me here today. I just want to talk to you really quick about community pharmacy in general and Walmart specifically, and how we can work to improve quality with complementary access points for adult vaccinations. So the National Vaccine Program Office has an adult immunization plan, and I'm going to show you how we plan to address each of the 4 goals that they set forth in that plan. So the first goal is to improve the infrastructure. So at Walmart, we work with a partner called STC, which is Scientific Technology Corporation, and they support us with population health through information technology. Currently, we are the only national pharmacy with real-time reporting into state registries, and with bidirectional data exchange with all immunization registries that have that capability. Right now, that's 41 different registries, not Washington, D.C. So what does that mean? That means that when we give a shot at Walmart, it is systematically reported into that state registry. Not later that night, not later that week. And the pharmacist has the ability in those bidirectional states to go in and query and bring back that patient's immunization history as complete as it can be from that state registry. I know that registry reporting is often a quality measure for electronic health records, but what is usually measured is the ability to report, not necessarily the volume of reporting or the fidelity of reporting. So I'd like to ask you all to consider with your own electronic health records, is this reporting systematic? And I was thinking about this earlier today when we were talking about those Z codes. How are we going to measure it? How are we going to improve it if we don't measure it? And if it's not systematic, all we're doing is asking providers to run faster and jump higher. Are they going to be able to run faster and jump higher? We should take down the hurdles, and we should make sure that our systems are improved in such a way that all of this reporting is done systematically, automatically, maybe through patient intake forms. Maybe we develop technology that can pull from SOAP notes information about previous incarceration. Maybe then we get our Z codes. Work smarter, not harder. So what we see here is the difference between 2012 and 2017. We have doubled the number of adults participating in various immunization information systems. So it's gone from 25% to 51%. And this is largely driven by pharmacy reporting. Now, why is that? Is it because pharmacies want to do the right thing? Is it because pharmacies are different from any other healthcare provider? Absolutely not. It's because regulation requires us to report. So if we're required to report, we report. But what we get is better data. So we need to not be afraid of data. We need to make sure, going forward, we can't stop the world from turning. That data is out there. It's going to be used. So if we get on the front side of that data and become that good steward that we are, then every single community can see this data as their power, not their risk. Access. So let's talk access for a minute. We all know that a lot of rural hospitals are at risk of closing. Here on the left side of the screen, we have the health professional shortage areas in primary care in the United States. Sometimes these are referred to as healthcare deserts. But on the other side of the screen, we see the pharmacist demand index. So those green states there, those have an oversupply. There's actually more pharmacists than there are jobs in pharmacy. In the yellow, the supply meets demand, and in that goldenrod color, there is a little bit of a demand, but it's not overwhelming. Now, is this to say that pharmacists should take over all aspects of immunizations? Certainly not. How many Americans do we have? Can we get them all a flu shot in the hospital, in the doctor's office, in the pharmacy today? We almost don't have enough capacity, even with all providers providing everything that we can. So let's think of ways to partner together to increase access in a way that is sustainable and is a way that benefits every community. How about demand? So this is their goal number 3, how to drive consumer demand for vaccination. So we don't have this equation quite figured out yet, but we're hoping people will come to us for immunizations, just like they come to you for immunizations. Quarterly, we hold Walmart wellness events. So these are events right in the front of the store. We ask the stores to put on a lot of hoopla around these events, get people over. We do not only immunizations, but we do free screenings. So free screenings for blood pressure, blood glucose, cholesterol, BMI. And since January of 2017, we've provided 2.2 million free screenings, which is about $6.4 million worth of screening activity. So these aren't diagnostic, they're just screening. We prick the patient's finger and we tell them, maybe you should see a doctor about that. But how powerful is it to get that message when these patients might have a fear of going to the doctor at all? They might not have a primary care physician. They may feel that any kind of health issue is a weakness. So getting them engaged in their health and actually into the system is something that we feel is incredibly valuable. We're also looking at new ways to leverage tools to engage and educate the consumer. Our immunizations you may need, we have this tear pad that just went out to all the stores. It's 5 by 7 inches. The pharmacist can make recommendations about which vaccines this patient should receive based on their medical history, based on their age, or based on their immunization history in the database. There's also a QR code on this tear pad. So the consumer can scan that code and it actually takes them directly to the CDC's adult immunization quiz. So this way they're getting information not just from us, but hopefully from another trusted source. And if that gives them more ownership of their health, because that's the other issue that we really have to confront, is that it is the patient's health. We can't sit there and tell them what to do. They're the one who needs to make that decision. So anything we can do to put information in their hands that makes that decision easier is something that we are very interested in. The other thing that we are working on, we have multiple initiatives planned with various payers and community partners like Sustainable Healthy Communities to drive patients with those immunization gaps into pharmacies for vaccination. So we're in talks with partnerships, bringing healthcare providers into our Walmart Wellness events. If they can hear the same message from different people, are they more likely to accept it? We just finished training with Sanofi at our annual, we call them Pharmacy Clinical Services Managers. These are the pharmacists who are responsible for all of the clinical services, so not just immunizations, but medication adherence and medication therapy management in their stores. Each one is responsible for between 10 and 15 stores. We get them together once a year and we provide them training. And so what we did in partnership with Sanofi this year was to give them vaccine confidence training. So this is training that teaches them how to talk to their patients. So when I say how to talk to their patients, what I mean is how to listen to their patients. Because what they've seen in multiple studies is that providers interrupt patients within about 23 seconds. We're not listening. So the first step in understanding a patient's worldview is to listen to what they have to say. Maybe they do have hesitancy around vaccines, and maybe it's grounded in something that's very real. They don't trust the government. They don't trust Walmart. That's okay. We need to get them talking so that we understand that, so that we know what to ask next, what to say next to get them engaged and to understand not just how the flu may impact them, but how the flu may impact their communities in a very specific way. Right now, consumers look at the flu like they look at car accidents. It's unlikely, it's nebulous, it's probably not going to happen to me. But if we can take this message and tailor it to the patient, this may cause you to end up living with your daughter, your overbearing daughter, right? How personal is that message and how much more powerful would it be? So innovation. This is one that, again, we're going to have to ask for every provider's help with. What we really need is more interoperability. The reason that Walmart partners with STC to do all of our state registry reporting is because of the onerous differences between state registries. A Walmart pharmacist can log on to the STC platform and it looks the same across all Walmart pharmacies. The Ohio registry looks nothing like the Arizona registry. They have different data requirements. They have different opt-in and opt-out. Some are for children only, some are for adults. All of this is managed for us so that we can have one platform, and that is, we found to be hugely valuable. How much better would it be if that were available to all providers? If we're all reporting It's just good communication. It's something that we do systematically, but it's something that provides value for everyone. This can also help potentially in our response to pandemic situations. We're always interested in Walmart at saving money and living better. We want to save money by making sure we don't duplicate vaccination efforts. How likely is a patient to remember their own vaccine history? And how powerful is it if we can get that vaccine history not only into the hands of other providers, but into the hands of the consumer themselves? STC is working on an initiative called MyIR, My Immunization Record, so that the consumer does have access and can see their own data. We also, as all providers have barriers, there are barriers in pharmacy. Most states operate on a system of standing order. So the standing order must be written. It has to call out all of the inclusion and exclusion criteria. It has to be signed by a physician. But in general, it's just the ACIP guidelines. There are multiple states across America, such as South Carolina, Oregon, New Mexico, Montana, with prescriptive authority for a pharmacist as long as it's within ACIP guidelines. If you could imagine just the administrative burden that lifts, it's huge. So I also ask you all to advocate for that, because I truly feel that we as providers cannot become more powerful unless we are empowering other providers. And I don't mean that just to physicians or nurses. I mean that to us as pharmacists as well. We need to empower our pharmacy technicians to do what they can do so that every member of the healthcare team can be in the trenches fighting this problem. We are working right now on training for screening for pharmacy technicians in states that allow. Can you imagine that we send patients home with a glucometer and tell them to test their own blood, yet there are health departments out there that say that a pharmacist is not qualified to check your blood sugar and tell you what it is? Thank you. See, irony. I feel that it's irony. So join me in feeling that that's irony. And let's all move forward to get these people into healthcare. I would like to personally invite you all into your local Walmart. Hopefully you remember, because it's less than 3 weeks away now, April 27th. Go in, have a conversation with your local pharmacy, with your local pharmacy technicians. See what they have to say about health, about population health, and what we can do to advance. I want to share with you, just in parting, what I think is a hugely valuable story. We got this from our last Walmart Wellness Day. This is a real story from Paragould, Arkansas. This was an event where a gentleman stopped by the table to have his blood glucose and blood pressure screened. His blood pressure was dangerously high. He reported that he did not have a PCP and was unaware of any high blood pressure. The pharmacist, Wendy, made a strong recommendation for him to go to the ER or urgent care. He was a Walmart associate and was too worried about missing work. Wendy was so concerned about this associate that she spoke to his manager with the associate's permission and asked if they could work out a way for him to leave to get seen by a physician. He left immediately and went to urgent care in town. The doctor that he saw there treated his high blood pressure and scheduled a follow-up appointment. The doctor ran a variety of labs, and when the results came back, his liver enzymes were extremely high. After further testing, it was discovered that he had hepatitis C. And we're happy to report that after treating, he is considered cured. So again, I thought what a huge impact that this had on the patient's outcomes, on the patient's life, just from a simple screening activity. And how many more patients do we have walking around without any knowledge of their health? How much economic burden could we lift from the United States if we were just identifying patients and connecting them to care earlier? Again, thank you so much for having me here. I really appreciate the opportunity to talk to you all, and I welcome any questions.
Now, with that being said, I think the first question I have is for Richard. So Richard, I saw you frantically writing down all the information that Stacy was talking about because she spoke about something in relation to data. So what is your take from this Walmart idea of being this mega superstore / pharmacy that is collecting all this information on patients?
That's an excellent question. I think, because one of our secondary outcomes was actually looking at where our patients got their vaccinations. We found that about 65, almost 70% of patients did get their vaccinations at our clinic, with maybe around 5% of patients having vaccinations either inpatient or at diabetes clinics, at dialysis centers. But there was a large part that was actually done in the pharmacy. But I think the thing that really spoke out to me about her presentation was Walmart working with immunization registries across 50 states. Because I think that's an essential tool for the providers to have on hand, to have quick access as to which patients of theirs have been vaccinated. So we don't do duplicate work on our end and press the patients about their pneumonia shot or their flu shot when possibly they just got it last week. It saves us time, just as it saves all of you time. But I would press you one step further because these immunization registries are sometimes burdensome and cumbersome to use in the course of a very busy day. And especially if you have a clinic that's geographically located in not just the center of a very large state such as Colorado or Texas or California, but if you're like in Delaware, you're located in like a 4 or 5 state area, Pennsylvania, New Jersey, Maryland, Delaware, that becomes a lot of registries to try to go through in one visit. So I think one charge I would have is, and since there's a lot of policymakers and advocacy here, is to encourage those who have the influence to encourage those who have influence over electronic health records to encourage them to integrate not just one state's immunization registries into the health records so it's easily accessible by 1 or 2 clicks, but multiple states and hopefully all states for patients who may be traveling from one state or another or migrating.
One interesting thing to note is with the media attention to the opioid crisis, what we find is that prescription drug monitoring programs have become more and more interoperable so that pharmacists and physicians can look at opioid prescribing across multiple states. We don't see the same thing with immunization registries. There's not the same urgency around it, but there is still the same need.
That's terrific. Now, I'm going to ask one last question, and then I'm going to open up to the floor, so you guys can all ask some questions as well. This one is going to Roslyn, and Dr. Foster, if you don't mind addressing this one. You had said that you pretty much go into the clinic telling patients, right, that they're going to need to take a vaccine shot or an immunization shot. How does that conversation typically take, both in the patient's room versus how Stacy has been kind of approaching it in a very strategic manner to say, kind of asking the questions as to why they don't want to take why they wouldn't want to take the vaccination?
Well, I've been practicing for 20 years, and most of my patients I know really well. And I've been doing this year after year, attempting to have them get the shot. It's just like with mammograms or colonoscopies. I said, she said no for 5 years, and I go, so I can go ahead and schedule you for your colonoscopy? And she goes, no. I said, well, can I get you a Cologuard test? And she says, no. And then I said, well, can you at least take home this take-home test for me? And she says, yes. So I've tried to incorporate that with the flu. We're giving you your flu shot today, and they say no. And I said, well, then we'll have the conversation. Then I'll give them a handout. They're coming back 4 to 6 weeks, and you say again, we're giving you your flu shot today. And sometimes you get, I'll get the flu shot. So just persistence.
And I just want to say, I definitely did not intend to say that we approach it differently, because part of the training was also that presumptive approach. We have to phrase it a little bit different in pharmacy. You can't have a patient show up for their metformin and say, you're getting your flu shot today. It doesn't really work that way in pharmacy, but we have given them the feedback in the training to say that if you start with a statement rather than a question, you're more likely to be successful. For example, you can say, we can have your flu shot ready when you come pick that up. That is more successful than if you were to say, you can have a flu shot if you want it. Do you want it, please?
Our nurses also have typically several shots in their pocket, or maybe 2 in the morning, and such that when they say, when they say yes, a lot of times they change their mind from the time they leave. So when they ask, they say yes, they get their shot. They don't get a few moments to think about it and come back. You don't give them time to think. You just pop it and you're done. So that's helpful too.
That's great.
So I'm noticing that no one really wants to, oh, well, never mind. We have one question on the floor.
Sam Marcy. I'm a family doc in Queens, New York.
Oh.
I also serve there as president of Family Docs in Queens, which I can proudly say is the most, that's with a capital T, the most diversified county in all of America.
Yes.
But I think it's all about, I'll borrow a term from our friends in real estate, and I think it's all about education, education, education. I've heard stories like the government is trying to inject something into me that will control me. You put those patients on antipsychotic medication, they'll be okay. But it's interesting what you brought up before, because about a year ago, I was asked to do some commercials about vaccination, immunization for vaccination against the flu. And it was interesting because you have to read from a teleprompter. And so I had to change it, and we wound up doing 3 different commercials, believe it or not, because gripe meant something totally different on the West Coast as the East Coast. And none of it really had to do with influenza, but it was tied to influenza. So because the community understood gripe to be whatever they understood it to be, we wound up doing 3 different 30-second commercials to satisfy the West Coast, mostly Mexicans, the East Coast with mostly Puerto Ricans, Cubans, Dominicans. And so it's about how you bring it about. I do tell my patients that flu can kill people. I don't tell them they're going to die. That will not grow my practice. But I do tell them that it can kill people. And we don't, after all these years, we don't have a vaccine against the common cold. But everybody thinks common cold and influenza is the same thing. So I think it's about education, education, and education. I wind up ordering 2 or 3 times a year because I run out. So, I guess I'm just venting what I see in the real world. But I think it's important that we get our patients. I don't understand to this date. I'm attending at a hospital for my patients. If I don't get the flu vaccine, I have to walk around with a stupid, I'm sorry, I didn't say that. I have to walk around with a mask, and I don't understand how people can do that and breathe your own air back in. They probably get sicker from that than from the flu vaccine. Now, every year I still get the flu vaccine. I've gotten sick from the flu vaccine. I know that we can say that you don't get sick, but I think you can get a mild case of flu from it. And I've gotten sick, so some of my patients will tell me that they get sick, and I tell them, it's okay. You'll do okay because you got the flu vaccine anyway. And then I guess they believe that. But thank you so much. I'd like to...
Thank you for that comment. So I just want to interject something, because I think you hit on something that's really critical, and that's around communicating around flu vaccination and the importance of flu vaccination and the need to tailor messages to your audience. Now, I showed you earlier, and everybody's aware that flu vaccination coverage, there's a lot of work to be done to improve vaccination coverage rates. and we need to meet people halfway. There may be people who don't care about getting the flu, but they do care about their hearts. They do care about keeping their diabetes under control. So we need to be able to communicate to people in a way that resonates with them. And if I could just add one more thing, the notion that the flu vaccine caused me to get sick, I think we need to change that terminology. The flu vaccine does have side effects, but if we continue to promote this notion that the flu vaccine can make you a little sick, it's going to feed into that narrative, that myth that people have about the flu vaccine causing illness. And one of the ways that people might want to frame the side effects from the flu vaccine is, I heard someone else, and I thought this was quite clever, was that the side effects that you might experience from the flu vaccine is almost like giving your immune system a test run, some training, so that when the real thing hits, it's prepared. So I think we really need to still be careful about how we frame the flu vaccine and the side effects. And just end with that.
Can I say one last thing,
Absolutely.
please? I think, is Dr. Ferdinand, is that you out there? I think there's a message here that's beyond vaccines and flu vaccines, and that is helping poor people or people with limited health literacy to better own their health and health care. And I think you're hearing these wonderful providers talk about how they use their whole team to empower folks to understand and do something about their care. And Dr. Ferdinand is working with us on a diabetes and cardiovascular disease project. And it's the same thing. The non-adherence to medication is very high. But the key is helping patients understand what's good for them and becoming their own advocates. So I feel like this is an empowerment of the people who are out there that we want to help.
Thank you so much, everyone, and thank you so much, panelists. This was seriously informative, and I think I myself have learned a lot more from this than I think many of you can see. I have a lot of notes here. I want to thank everyone for listening in on this wonderful panel, and we will give you guys a short break. Thank you, guys.
Thank you, Alazar. Thank you, guys. You were great.